Thanks a lot, Joanne, for this nice introduction. It's always a pleasure to come here and to always meet very interesting people. So when I went through the list of people who registered for this evening, it was actually hard for me to decide what can I show, right? So I made a selection, so I hope there is something for every one of you. If you have pressing question during my presentation, please feel free to ask and raise a question. Otherwise, we also have a bit time after my presentation for some questions. So let me actually start with an example to give you an idea what connected healthcare could be, right? And one of my examples I usually use is an electronic personal stress assistant, right? So it's something that continuously monitors your stress level, because every one of us is stressed nowadays, and then suggests how to better deal with stress, okay? And from that example, we can understand what is really important for us. Because in order to continuously monitor something, so to continuously monitor a certain health condition, we need so-called unobtrusive sensor technology. Right? I mean, no one would like to have a 12-lead ECG and maybe EEG and maybe some other cables around in daily life. We would like to have sensors that basically are invisible, right? So that are part of our clothes, part of our environment, and still be able to measure health-relevant information, right? And when having all this information 24/7 in an ideal case, we can imagine that this is a huge amount of data, right? So what we need in order then to come up with meaningful conclusions out of that data, for example, to understand what is our stress level, we need the right data processing and data modeling tools. So methods that are able to deal with this huge amount of data, methods that are able to deal with data that comes from daily life, right? Not from a kind of a clinical controlled setting. And finally, we would like to change something in people's behavior, so we need those kind of interfaces, and we have to design them in a way that people actually change something and that they keep the change, right? And so we are working actually in all three of those fields, and I will give you a few examples today, what kind of research, what kind of work we are doing in those fields to give you an idea, I mean, what are the challenges and what are our approaches to come up with a stress assistant at the end and come up with other important electronic health assistants that can help hopefully all of us. One important thing is that to give you maybe the big picture, right? So starting from the example now, looking at the field in a more general way. So we foresee actually a similar kind of revolution that we have seen when it was about the transition from those mainframe computers to mobile computers, right? So 40 years ago, computers looked like this. Right? So they were highly centralized, and only very specialized professionals were able to work with those computers. Right? Nowadays, in the area of mobile computing, we have a decentralized approach, and everyone nowadays is working with a computer because everyone has a smartphone. And we see actually a very similar transformation when we talk about healthcare systems, right? So nowadays we still have this centralized model. We have highly specialized professionals that treat ill patients, right? And we would like to move to a more decentralized system where people are caring more for their own well-being. If you look at this metaphor, you might realize that nowadays we still have the mainframe computers. We call them different. We call them the cloud, right? And of course, we know that without the cloud, mobile computing is not working at all. And the same is true as for our connected health vision, that we don't want to close the hospitals, right? we want to add something like this decentralized way of operating health, right? Because we need both. Where are we? So I would say we are somewhere between the horseless car and autonomous driving. So we already have a quite good idea how our autonomous car looks like. However, we still don't have all the technologies needed to make this vision a reality, right? And today I will show you a few examples how we work to actually have this autonomous car at the end. And very important thing to mention is that all the work we're doing is highly interdisciplinary. So obviously we need health sciences, right? Because we are working with health-related issues. Obviously we need knowledge about sensors, right? Because it's about measuring health-relevant aspects in daily life. And with all that data, we obviously need knowledge about data science, right? Because we need to process all this huge amount of data. Well, and here I have a few interdisciplinary projects that I was involved in the past. So one I already mentioned, the personal stress assistant, but we did also work on using smartwatches for supporting the treatment of Parkinson, or using sensors in the bed in order to monitor sleep-related issues. And we did not stop with the smartphone. We also investigated how we can actually use robots to actually build interfaces. And for all those project examples, I have a few slides to give you a better idea what we are doing, to give you an idea what are the challenges we need to solve and how the results look like at the current state. So when we would like to build this stress assistant, right? When we would like to investigate stress, as I said, it's again an interdisciplinary field of work. So the most important thing is that you collaborate with psychologists, right? Because they are the experts in stress, and they are also the experts in how to stress people, right? Because if you would like to come up with a stress assistant, in order to develop that system, you need to stress some people to understand how your system is working and how you need to design your system. And they actually came up with a very nice concept. So this is a cognitive stress task. It's basically an app, right, where you have to solve those kind of tasks, and you have a certain amount of time to solve that, right? So what the participants of that study did not know was that this program was faked. Faked in a way that it adapted to your personal ability to solve those tasks. So if you're really good, if you're really fast in solving those tasks, then what the program did, it realized it, and then the next round, it simply increased the difficulty of the task and reduced the time you had to solve those tasks. In addition, so with that, no one was able to solve more than 50% correct, right? In addition, what we showed the participants was their own performance in comparison to a so-called norm collective, so to normal people, right? And we told them you always have to stay here in this green field, so to have a good performance. But since the program was faked, of course, everyone, you know, quite fast went to this kind of red field. And, you know, if you make people believe that, you know, others are much better than you, then they are becoming stressed, okay? But that was not all. So psychologists told us, well, we need to add more stress, actually, to make it more realistic. So they came up with social stress. And this means, so from time to time, the experiment leader entered the experiment room, and then she started to ask some questions, right? So for example, I mean, she told the participants, look, maybe you have problems with the keyboard, right? Maybe you can't answer those tasks correct, or can you read the tasks well, right? And of course, the participant said, no, no, everything is fine, right? And then she started asking more moderate questions like, did you sleep bad, or are you feeling bad today? And then she even asked questions like, I mean, do you take drugs, or do you already had these problems in school, right? And this is then, of course, the second social stress component where people really get stressed, right? And I mean, to give you an idea, I have a short video to show you how it worked. So we first showed the kind of sensors we were using. So basically, we measured the heart rate. We also measured the pressing rate, because these are important values in order to measure your stress. We also use devices to measure your electrodermal activities. Basically, it measures when you start sweating, and when you are stressed, you start sweating. Then we use this kind of sensors that measure your movements, and also the audio and the video. And then the participants had to fill out also a lot of questionnaires to get an idea about what kind of stress type the person is. And then he got the instructions. But first, we also took these saliva samples, because when you are stressed, then you can measure it in your saliva when you look at the cortisol levels, right? And I show you later that this kind of measures was, for us, important to prove that we could really stress the people, right? And now the participants get instructions.
Now you're going to do the computer test?
Right, and she explains him now that he has to do the calculations, that he has a certain amount of time for it.
Let's see if I have around here. This is your performance, and this is the performance of a sample?
Yeah, he told him that, oh, sorry. He told him that he needs to stay in that. Okay, and so now he's doing the test, and of course, since the program is faked, right? It's really hard to compete, right? So I mean, as I said, he's not able to solve more than 50% of the tasks correctly. And of course, we told him that we monitor everything in the control room. Of course, everyone is aware of his bad performance. And that's why now he gets the first feedback, okay?
Well, this was not so good. Is there any problem with the keyboard?
No, it was just very hard to click so fast. It was unreal.
Well, this is very unusual, so I just have to call my supervisor.
Yeah. So, I mean, she gives him the feeling that it's his fault, right? So, for everyone it worked perfectly, but only for him it's really that bad, right? And so in the second round, I mean, he again tries his best, right? But he has no chance, right? Because still the program adapts to his maybe even increased abilities to solve those questions, and I mean, he has no chance, right? And he's getting nervous, and we can measure that, for example, with the movement sensors. And now he gets the second feedback.
No? So this is not going very well for you. I look at your results and they're really under average in comparison with our other students who done this test before, and I don't really understand why. So you have, did you have problem sleeping? Taking any sleeping pills?
No.
Or any other pills or medicines?
So again, she gives him the feeling that it's his fault, right? And that others who did the same test all passed and had really good results, but he's not able to do it.
Time is too short, so you can't solve the exercises in the time. Yeah.
In the school, do you have to try a problem?
Yeah, and now she asked about his school problems, right?
First grade was okay. Yeah, okay. And you passed all exams until the graduation. Okay, and now you're studying. You're a student. Yeah. And found themselves is incredible that you yourselves are not better. You shouldn't be able to
It's just,
spot yourselves.
no, it's default.
Type speed is exactly the same for all people.
Right, she tells him, I mean, for everyone it's the same, right? And everyone so far really passed that test successfully, and she again motivates him to, you know, do his best to show better performance. And he tries, of course, but again, he has no chance, right? Yeah. And now she even tells him that, you know, it costs a lot of money, it costs a lot of time that we're doing this experiment, so he's now really in a quite bad mood. And now she's standing even behind him, right? Okay. And I mean, think about yourself, your boss is standing behind you, right? And observing how you're doing, and you know at that moment your performance is really bad, right?
So it's really not going well.
Yeah, and she says it's not going well, right?
So you feel stressed by that situation, or?
Yeah.
It's really suggested there's nothing wrong with it. It's supposed to be like that.
Okay, at the end, of course, everyone got a debriefing, right, and was told that this was actually not a cognitive experiment where we invited the people, but it was a stress test, right? And then, of course, everyone is relieved, right? Okay, so for us, it was important to really stress the participants in order to get data, right? So data when persons are stressed, and we invited them also a second time, but then in the second time they had to solve the same kind of tasks, but this time without this kind of social stress and this kind of stress that were induced when you show people that they have a bad performance, right? To have basically data when they have a cognitive load, and then we could compare this kind of so-called control conditions, so when people are having, I mean, when people normally working, and then compared with the stress condition. And I showed you the saliva samples before, right? And here we can clearly see that it worked, right? Because in the stress group, or in the stress condition, the cortisol levels are significantly increased, right? So this was somehow the proof. And just to give you an example, I mean, we analyzed all the sensor data that we have recorded. I just show you here an example from the data we got from this hand measurement. So this basically measures the so-called electrodermal response. It's actually the amount of sweating, right? So this kind of signals are also used in lie detectors, right? Because when you are lying, you have an increased cognitive load, you are stressed, and this can be measured with your increased amount of sweating. Nowadays, I show you later, we can actually measure this with a smartwatch. So what you can see here, just to give you an idea, is the signal that we get out from that experiment, and you might realize that in the middle part, the signal looks totally different than in the beginning and in the end. And the reason is that in that part, this was actually the stress situation, right? So you can really see that the signal indicates when the person was stressed compared to the baseline and compared to this kind of recovery phase after the experiment. Of course, you might now ask ourselves if you see such a sensor, whether this fulfills our definition of an unobtrusive sensing device. I would say definitely no, right? So no one would like to wear such a device. The good news is nowadays those devices look like this, right? So the famous one, it's called Empatica. It basically measures the same that is measured here from this own designed research prototype, and I mean it looks much nicer, and I mean people wear it, right?
What's it called again?
Empatica. Empatica. Yeah. So having nowadays those nice devices, smartwatches, for example, we can actually do a lot with them, right? And just to give you another example, I show you here how we can use those devices when it is about supporting the treatment of Parkinson patients. So for Parkinson patients, it's very important that they receive their individual right dosage of the medication. Because if they get a too low medication, then the symptoms do not change. If they get a too high medication, then the difficulty is that they get used to it, and soon the medication is no longer working, right? So the neurologists actually have the challenge to find the right dosage for the individual patient. And state of the art is that the patient comes to the doctor, and the doctor diagnoses the patient, then tries to find out the right dosage, and then sends the patient away. The point is that the neurologist does not see the patient condition when the patient is at home, right? And here we can really help with those smartwatches, and that's why I have this video here. So you see here, that's the patient, that's the doctor, and in the graph below you see acceleration signals from both hands of the patients recorded with the smartwatch. And so red is from left arm, black is from the right arm. And now the patient is sitting here, and you might realize it's hard to see, but you might see that this black curve is still has a high variation. Also, the patient is sitting in rest. And this shows us that actually the patient has on one side, I think it's the right side, he has this kind of tremor, right? And we now can even see it more. Now it's standing in rest, and you see the black curve shows this peaks again and again, while the red curve, so the other hand, is basically in rest, right? So this kind of study was for us important to understand that we can measure symptoms of Parkinson, like the tremor of the hand, with consumer smartwatch devices, right? And of course, we're not the only ones. So for example, Apple has a huge research program on doing very similar research, right? So using the Apple Watch to measure symptoms of Parkinson in order to get health relevant, or Parkinson, in this case, relevant data from daily life of the patients. Another project that I would like to mention is using sensor to do mobility analysis during night, right? And so the important thing that I learned in that project is that actually a movement during night is very healthy, right? So if you're unable to move during the night because of some health condition, you have a high risk of developing this kind of pressure ulcers, so this kind of infections. And those are very painful and take a very long time to heal again. So what these elderly facilities usually do to prevent those kind of diseases, they wake up the patient every 2 hours in the night and move the patient from one side to another, right? The thing is that they do it because they believe that the patient might not move enough. However, by putting sensors in the bed, we can actually measure the movement of a patient or a person. And with that measurement, we can tell if it's needed to relocate that patient or not, right? And here, let me show you an example from a healthy person. So you see the night starting at 11 to 7 in the morning. And those black lines you see here, those are movements, so-called significant movements, right? And you see here that we move quite a lot during the night. So on average, we have 3.5 movements per hour, right? And this is healthy, right? Because otherwise, we have the risk of developing these infections. Now I show you an example from a healthy person, from an elderly patient, sorry. And here the interesting thing was that that person could not really sleep, and she got sleep medication around 2 in the morning. What we then can see is that she basically stopped moving. So this medication was obviously too strong, right? And so she did not move for more than 2 hours, and that's why the systems actually raised an alarm. And for me, the fascinating thing on that project was that we could make the night movements actually visible, right? So the nurses did not know before how much the person was moving. And this information was so important for their kind of treatment of the person that for us it was really very interesting to support that kind of a treatment in elderly facilities. Finally, I give you an example. Remember when I showed you the kind of first slides, we had those 3 research areas, so sensors and methods, and finally interfaces. So usually when we think about interfaces, we all have the smartphone in our mind, the smartphone which somehow tries to motivate to change our life. But this project was about to show that, I mean, there is much more than the smartphone. It was basically a project where we investigated children in a rehabilitation facility, and those children had to perform exercises every day for a few weeks. And you can imagine that children, I mean, maybe the first or the second day is fine to perform all those exercises again and again and again, but on the 3rd day or so, they are tired of it, right? So you need to find something to motivate the children to do those movements again and again and again. And so the idea here was basically to use a robot. And that robot was able to communicate with the child and was able to tell the child what kind of movements she should do. And the child has here some sensors. And with those sensors, we can measure the movements of the child so that the robot understands how the child is moving, right? And then the robot can give in real-time feedback whether the movement was correct or whether she should, for example, repeat that movement, right? So we had basically a closed-loop approach. And for us, one of the important results was that the childs were asking us whether they can take the robot at home, right? Unfortunately, we did not have so many robots, right? But for us, this was the important sign that the childs really liked it and the childs really played with it, right? And so without realizing, they did all their exercises in a playful way. Okay, so finally, let me show you a few projects that we are currently doing. So one of the projects we are doing in cooperation with Erwin Böttinger's group is measuring blood pressure, right? And you might now ask, I mean, why we are in blood pressure measurement? I mean, this is solved since years. No, it's not. So if you ask, then medical people will tell you that this single blood pressure measurement that you can get from your mobile blood pressure device is actually useless, right? So you need to measure it at least 24 hours, right? In particular during the night, because some people develop high blood pressure only during the night, right? And I did it once. You know, you can get those devices. They inflate this cuff every 20 minutes, and then the measurement is done, and then again and again and again. And it's really a pain, right? Because you can't sleep, of course, when this thing inflates all the time. Also, you know, think about wearing it now, right? So when this device would go on for some of the people here, it's really not unobtrusive, right? Interestingly, there is evidence that when you measure the so-called pulse transit time, so it's the time that the blood takes from your heart, for example, to reach your hand, right? That this time is a quite good indicator if you have high blood pressure or not. And what you need is you basically have to measure the ECG, so to understand when your heart contracts, so when the blood actually leaves your heart. And then you need another measurement on the arm to understand when this blood wave actually arrives there, and then you can calculate the timing, right? So you need at least 2 sensors to measure that. And in this experiment, we also use the traditional blood pressure device to get the ground truth measurement, right? So, so we have already completed the kind of pilot study, and we are now recording a lot of data from patients, and we hope that we can come up with models that can measure blood pressure in this unobtrusive way, okay? Important here to note is that we obviously need more than one sensor, that we need more than a single smartwatch. And this is not only true in that project, that is true in many projects, that we need to combine different set of sensors. And now comes the challenge that those sensors are produced from different companies. They have different data formats. They have different ways of how to access the data. So in short, it's a pain to work with many sensors at the same time. And that's why we are developing so-called sensor hubs. So basically, smartphone apps that are able to combine different sensors from different manufacturers and to store those sensors into some cloud storage and then to make it accessible in a single data format, right? And this is really needed for many use cases. So whenever you need more than one sensor, actually, you need somehow this kind of a sensor hub. Another interesting project we have is something that we are dealing a lot in our projects is the so-called comfort quality dilemma, right? So here as an example, we have here a medical ECG, right? So with those wet electrodes on different positions of the body, and you get a perfect signal, right? What we would like to have at the end is those ECG measurements with textile electrodes, so electrodes that are incorporated in our clothing. The thing is that, you know, the signal quality varies then a lot. So if you are sitting still, then you still get a good signal, but as soon as you start walking and moving around, then signal quality gets very, very low, right? And in order to detect that, in order to understand when you get a good signal and when you have a bad signal quality, we are nowadays utilizing neural networks to detect when signal quality is good, so when we can use it for our data analysis, or when signal quality is bad, when we better do not analyze that kind of data. Finally, a project I would like to show you that deals with so-called distributed machine learning, and that targets actually a very serious challenge that we have, namely how to combine different data sets, right? So in medicine, the highest standard are those multi-center studies. So when you combine data from different hospitals, right, to make sure that you have data from different kind of patient populations. What you need to do as a first step in order to do those studies is to collect all those data in a single place, right? And this data collection is just the important first step, right? So, and it takes years, right? And it takes years because you need to comply with all the ethical issues. It takes years because every hospital has a different data formats, have different hospital information systems. Here in the US, the situation is a bit better, but believe me, in Germany, it's even much more difficult, right? So I remember that Charité, so it's Europe's largest hospital, approximately the same size like Mount Sinai here. They recently did a survey how many hospital information systems they have in the single center, and they came up with almost 400, right? So even if it's in such a big institution, combining those different data sources is really, really difficult, right? And so our idea is now actually to no longer share that data, so no longer, you know, collect this central data repositories, but to actually share models, right? And how is this working? Well, let's assume we have a neural network, right? And let's say this neural network doesn't know anything because it's really in a kind of initial phase. Now, we send this neural network to, let's say, hospital A, and we let the neural network train on the data from hospital A. And once the neural network is trained with that data, we send it back to our central neural network instance. And then we send it to hospital B. We retrain it with the data from hospital B and send the retrained network, so the weight updates, back to our central model instance. And we do it for every hospital. So in this case, we actually no longer exchange data, but we exchange models, right? And so we already know how to do it in theory. So we have implemented everything. We have simulated it with data sets. And now we are at the point where we really would like to try it out in practice, right? And really would like to show that it's working. And of course, that would like to show that it no longer then takes years to combine all those different data sets to have multi-center studies, but maybe that it just takes a few weeks. Right. Okay, with this, I'm actually at the end of my presentation. Here is my current team. So I showed a few of the projects, like the distributed federated learning from Piane. We have a few more, like doing voice analysis from stroke patients, for example, to understand their progress in rehabilitation, or doing gait analysis for Parkinson patients, and many more. And if you're interested, go to our webpage. You always see the link below there, or search for Connected Health at HPI, and then you see our ongoing projects. And I'm happy to get in touch with you. If you have any interesting connections, then connect with the Connected Health team. And of course, now I'm happy to answer all your questions. Thanks for your attention.
Yes, hello. Quick question. I didn't quite get the difference between models and data. Can you just elaborate a bit?
Yeah, so I mean, in order to build models, you need data, right? So we say we train those neural networks on data, right? And the idea here is that the old way is that we first collect all this data in a central place, and then we train our network on all this data, right? And the different approach here is that we no longer collect data in a central way, but that we send those models to the hospitals and do the local training here, and then send the models back.
I understand, but it's the question of, that I understood, it's the question how you then use the model, that you can use it like a data-driven insight, because now you have a very smart model that incorporates data, incorporates models from each and every one of the hospitals.
Yeah.
So what I didn't quite get, because I'm a bit thick, is what the model that you then get, can you exemplify how you use that? So that basically is turned into something that is the best of what each has to offer, is that it?
Exactly. So I mean, what we have at the end is basically a model that has seen all the data from all the hospitals. So that it has seen basically all the patients from all the hospitals. And in this way, we make sure that, it has seen all the different patient characteristics. Because, if you train a model on a very, let's say, special data set, so I don't know, patients that have just a single condition or so, right? Then the neural network can, of course, only learn that single conditions. But if you have in reality 10 different conditions, you need to provide the net the data from all the conditions so that the net can actually learn it. Right? So the net can only be as good as the data you provide. Right? And that's why it's so important that you feed the network with all the different data. And that's why in medicine, the highest standard is to have this multi-center study. So to use data from different institutions to build those those models. I don't know who was next.
I was wondering if you could talk about how wearable devices and wearable technologies have the ability to redefine how we, like what biological processes are. Like for example, your ECG monitors, right? Like what we have as gold standard medical technologies is great when you're in the hospital, but we have all these devices that are attached to people all the time. Is that changing our ability to sense or to see new biological signals from these longitudinal devices?
For sure. I mean, what actually already happens now is that more and more people, for example, using the Apple Watch, right? And more people then go to the doctor when the watch detects some symptom and say, look, the watch told me that I should go for a checkup. The thing is that we are not prepared for it, right? So we're not prepared for it that we are not able to import that Apple data into our electronic health records, but this is valuable data, right? So we have now a huge discussion how to make this electronic health cards and how to exchange electronic health data between the hospitals. This is everything, it's important, but it's not enough. Because soon, very soon, we will get more and more health-relevant data from all those Apple Watch devices, and so we need to be prepared for that. Because we can generate a lot of knowledge that is so far simply unknown because we don't have the data for it. Yeah.
Great presentation. On the sensor hub that you mentioned, does such a meta app exist right now which draws in really all the different information that's available? And if so, is there now a follow-up app to that then uses this metadata to nudge behavior that is conducive to one behavior or another?
So the app is existing. It's not able to connect to all devices because this is not solvable, right? Because every week there is a new device on the market. So what we do is we start with the most popular devices, like smartwatches, like Fitbits, like others, and we continuously improving the app and developing the app. So whenever there comes a new sensor out, an important one, or whenever there is a sensor update, then we do a short maintenance of the app, so to make sure that we are always up to date. I did not get the second part of your questions regarding the behavior.
Yeah, the thing is, one aspect is to measure what's going on, right? Yeah. And then the second step is what you use this information for. Now, theoretically, once you have all these subtle and less subtle information bits, you can measure what's going on, like really at every part of the human being. So how can you now use that to induce certain behaviors that are conducive or not to the health outcome that you want to have?
There are principally two ways. So one way is to provide a good interface to the medical doctors, right? So to provide them insights in all that data so that we support their kind of therapy, like in the Parkinson example, right? To show the kind of tremor the patient has at home, to give the neurologist the feedback whether the dosage of the medication is right or not. The other way is to directly provide that feedback to the patient. Like Apple is doing it with their atrial fibrillation diagnosis, right? And whenever they measure some risky data, they at least issue a warning, right? And then tell the person, better check that up because you might have a problem. Right? So that's are the two general ways. We are still in the beginning of it, right? So we don't know yet. I mean, we know that parts of it are working, but we also know that we have huge challenges that, for example, if we would like to induce behavior changes, that those behavior changes really last for more than a week or a few weeks, right? So we have, for example, the challenge that people, when they start using wearable fitness devices, they use it for, I think, on average, just a few weeks, and then they no longer use it, right? So, and if you look who is using those devices for longer than a few weeks, then those are usually the people who are already fit, right? So sport people who then say, oh, it's perfect, now I can measure even more and can share with my friends. But maybe the 80% of the people that do not use those devices, they might benefit most from it, but they still don't use it, right? So there is a huge mountain of work in front of us in order to come up with solutions that, you know, not only works for those who are already using it.
Do the hospitals easily cooperate with using your models? It's more work for them to put their data in your format. Do they cooperate, or do they say, no, this is too much work, we can't do it, find somebody else?
Well, very good questions. I'm in this kind of interdisciplinary work since now almost 20 years. And I remember, so almost 20 years back, I had to convince a lot of medical people to work with me to do something with medical data. Nowadays, it's changing. So more and more medical people come to us and bring their data, or at least say, look, we have here interesting data, and we would like to extend this data. Let's do something together. So nowadays, it's much easier to find open-minded medical people who would like to try out whether, for example, smartwatches are somehow beneficial to support their patients. Because now there's also a new generation of medical staff, and so I'm really happy because this is now really a very exciting time, right? Because everyone, or many people realize that there is a huge potential in this technologies, and so it's nowadays it's actually no longer that problem to find collaboration partners for us.
Hi, privacy. How do you deal with privacy? I know there's like HIPAA compliance. There's also, like, you know, I'm from a technology company. You got to deal with either, you know, safe harbor kind of processes or expert determination. Do you keep identifying data of the patients, or do you de-identify the data and store it in aggregate for the hospitals? How do you deal with that?
Yeah, again, a very good question. So de-identification is a very important thing. We even go one step further, I think. So, you know, having all this data, so there's one idea that in the future people can donate their data, so their de-identified data for research projects, right? Because I mean, all those powerful methods like neural networks only work if you have enough data, right? And so you need many people to participate with their data. And so the idea is that with data donation, with de-identified data, people can be part of this research. And hopefully we can make a closed loop. So whenever we are using data from a person, we then can later provide feedback to that person what actually was the outcome of the study when using at least parts of the data, right? So from a data security point of view, I think we have a good idea how to do that. We are still not that far that it's actually really working, but it's very close.
I'm kind of coming at this from a business point of view, and how are doctors receiving this type of information? Are they happy with it? Do they feel that they can, you know, it looks like you're trying to get other people away from going to the doctor so much with all of this wearable technology. You don't have to go in for your EKG, you can do it on your iPhone and send the PDF to your doctor. The doctors might not be getting paid for such a consultation. I'm not sure how healthcare works in Germany, but in the United States, you know, there are a lot of issues with healthcare and getting doctors paid for these types of visits. Have you found difficulty there?
Definitely yes. so it's again a very important question where I can't provide the whole solution to it. So I mean, what we see is, I mean, I just mentioned we have this open-minded medical people, of course. On the other side, also we have a lot of concerns, right? So for example, if you record 24 ECG 7 days a week, I mean, no doctor can screen those data, right? So you need to come up with methods that find the interesting parts of that data and then guide the doctor how to use that kind of data. When you say we might prevent people from doctors, it could also be the opposite, right? So when people using this Apple Watch feature to detect symptoms of atrial fibrillation, there might be even more people going to the doctor because, I mean, I think Apple and others are quite careful in, you know, not to oversee a symptom. So they, I mean, they usually send doctors more often to patients more often to the doctor than actually needed. So it could also be the opposite way, that, you know, more people going to the doctor because they get some warning from all their kind of devices. So these all those questions.
Also the teledoctor.
Yes, yes. Of course, these are current discussions and considerations why we always have to go physical to the doctor and why we don't change it from time to time to some telemedicine consultations, right? So I mean, the technological developments are basically there, but as you mentioned, I mean, there is much more that needs to be considered, like how's the payment model.
Actually, it's funny that you mentioned that. So my question was about utilization and how that's sort of impacting the population setting when you have a bunch of people now seeing the 1 to 2 million results of their healthcare. How does that impact that population? Do you see increased utilization or decreased?
You mean utilization from the devices, or?
By just going into their healthcare facility or setting. Do they go often to the primary care physician, and how does that generally impact?
I don't have data about that so far. I think soon we will see that, right? I mean, this Apple feature is maybe out for half a year or so, or a bit longer. But I think it's too early to tell right now. But very soon we will understand that, right?
Hi, thank you very much. And this slide that you're on here is great. The sort of a two-part question. First part is that sort of, machine learning AI is really pattern matching. And one of the big issues is how can you put a filter up there early to differentiate between where you've got good patterns, say diabetic-caused diseases of the back of the eye, versus where pattern matching is useless, which is say like neurofibromatosis. And then taking that one more step, part two of the question, the wearables are great, right? It's like one of the big test cases for that is around brain aneurysm, right? You've got the unruptured aneurysm, right, which is there and you could see it on a scan, but it hasn't burst yet, the person isn't dead. And then those where you just have weakness. And there's a lot of hope because you've got this whole group of cases where people come back from working out or senior citizens doing mall walks, they have an aneurysm, they drop dead and they're dead, drop to the floor and they're dead in a week. So that's one of the good cases for that. Given the work that you're doing, how do you see you interacting, whether it's aneurysms or something else, with this issue of, AI is not really intelligent, it's sort of mathematically stupid, right? It's just doing pattern matching from, analyzing handwriting. How do you filter those, and then how do you use that wearable, so you can do these massive cost reduction things like, say, the state of California is trying to?
Yeah. I mean, one very important aspect in that direction is to investigate, we call it transparent AI. So coming up with methods that we can actually explain how this model works at the end. This is very important because, I mean, the medical people are asking us, I mean, how our model works, and they need to understand it, because if they rely on it in making their diagnosis, for example, they of course have the right to understand how it's working. The thing is that nowadays those models are very, very complex. So they have thousands of neurons, or even millions of neurons. They have many different layers and so many connections between those artificial neurons. So it's getting more and more complex to understand how this system is working, right? Because when using those systems, we no longer program them in a way that we provide some rules and say, look, if this pattern here, then do that. If this pattern, do that. No, we just show those models the data and tell them, look, this is data from a healthy person, this is data from a deceased person, to make it simple, right? But at the end, we need to understand, I mean, what kind of patterns the system has learned. Because there are a few examples where actually the system learned the wrong patterns, right? When people really inspected the network and really try to understand what kind of patterns the network learned, they were surprised because they realized, oh, this is not the right way to detect this kind of disease, right? For example, right? So that's why it's really important research line. So we are doing this kind of research at HPI because we recently got funding for creating an AI lab. We will also do the MOOC courses that were mentioned in the beginning. And part of that is also to investigate transparent AI. So to really come up with methods where we can inspect those models, and many other researchers around the world doing the same, because this is a huge issue nowadays.
Question about privacy. So I was wondering if there is a concern that the model itself can leak some information about patients. In particular, for example, hospital number 1 has a patient which is very rare in terms of characteristics, and the model basically learns the specifics of that particular patient, and then you send the model to hospital 2, and from hospital 2 somebody can, you know, leak from that particular model. Is that a concern? Or?
It is definitely a concern, and it's actually part of the PhD thesis of Piana here. So he's exactly working on that direction. So for example, what would happen if there would be an evil hospital, right, who would try to present the network with data that actually is nonsense, or in the worst case, that actually brings the network in the wrong direction. I think it's not that realistic, because I think usually we can trust hospitals. But anyway, I mean, it's an important question to make sure that following up those approaches, that, you know, nothing goes wrong in the different sites. So that's why the questions you mentioned are definitely research questions. And so if you're interested in please check for Piana, because he is working on all those topics.
Thank you. One question, the maintenance of the model, because you mentioned that you send the model, you just train it, then you combine all of them to a big model. Is there a continuous process for checking for the model that is deviating, and how do you do feedback to train again? Like for example, also if you're able to detect that a change in protocol in that hospital, making things better. So it's mainly the maintenance of the model.
Yeah, again, a very, very important thing. The point is, this is only working very well if the hospitals would use the exact same kind of data formats. Of course, they don't, right? So that's why it's still a huge of effort to bring the data from the different hospitals in a format that you can retrain the models in these different hospitals. But this kind of work you have to do anyway, even with the centralized approach, right? When you collect this data first from all the hospitals, you have to bring it in a format that is unique, so that you can then build your models, right? But you're right, of course, this is one of the issues that need to be solved in order to make this distributed learning really working. As long as we don't have the interoperability between the different hospitals. And this will take years until we have it.
I have a question. Wouldn't it be useful for these models to learn from the data about the patients where treatments succeed or fail, or interventions in general succeed or fail, and to hone interventions so that they are more appropriate for individual patients?
I mean, in general, those models are trained for all the cases, right? So for procedures that fail, but also procedures that went well.
Do you monitor the outcomes? Because it seems to me that one of the best things these mass models with massive data could learn is to tell a doctor, if you give that person this medication, based on all the other people like him, he's likely to get worse. And if you give him that medication, he's likely to get better.
Yeah, it's a very important point. So it goes along the kind of data collection or data pre-processing. So what is very important in those kind of fields is the so-called follow-up. So that you not only have the data about the patient condition, but that you follow up the patient for a certain amount of time, right? This can be a year or 10 years, to understand what's the patient condition, right? So this also means that for some of those studies, you really need time. So you need the time to see, you know, how the patient is developing, right? Before that, you can't really build your model. So having a good follow-up for all this data is a very crucial point. Yeah.
You asked, but I did want to ask you your choice for the test group of the symptoms or activity for Parkinson's and tracking. Was it solely for medication purposes that you either were led to this, or maybe there was a group that wanted to study those medications specifically? Are you thinking about developing or utilizing that technology to assist those perhaps who have another form of a dementia diagnosis under that umbrella, or Alzheimer's disease?
Yeah, I mean, in that project, we not only looked at, for example, the hand tremor, we also looked on the gait. Because the gait, so I mean, for example, if you have a regular gait, in general, the kind of gait variability you have is a very important figure to know when you diagnose the patients. This gait is also important when we talk about, like you mentioned, dementia, right? Because we know that the gait parameter are influenced by a lot of health issues. Actually, there was one paper, recent paper, that claimed that they can estimate your time of death based on your gait analysis, right? And so the reason behind is that you know, if your body constitution somehow reflects in your gait parameters. So if you have a stable gait, or if you have a high variation in the gait. So this kind of analyses are not only for Parkinson's disease, but you can use them in many different health conditions. Yeah.
I work for a pharma company for a long time, and this is a controlled clinical trial process. They do have real patients, and they do try different dosage of the medicine to see what works for what type of population. So it's controlled, and it's not machine learning. It's based on real clinical trial data. But I do think going forward, machine learning can probably come up with even more model for the doctor to consider how to treat the patients.
Quick question here. You know, very interesting presentation, but in terms of modeling, the quality of the data is most important. So how do you, are there areas into medication adherence, especially, you know, in the hospital setting is pretty well controlled, but in the home setting, dosing, just mentioned earlier, and also socio-economic health and even different ethnicity. You know, BMI 25, BMI for Asian, BMI 23, for example. Are there studies going into that area to get further clarity in terms of segmenting different population in those areas from a more dosing, medication adherence, and also how different people built differently? Yeah. And how the social system happen?
This is one of the many reasons we're actually very happy to work with Mount Sinai, right? because here in New York you have a very interesting patient population, right? In particular in Mount Sinai. So when I first have seen the kind of different ethics that are there, right? I mean, it's really I think a very unique mix that you have here in New York that we, I think, don't have in German cities, right? So that's why the data set of Mount Sinai is so interesting for us, because we have data from those many different ethics, and of course then the question is whether certain medications work differently in different ethics. And I mean, I'm not an expert in that, but I'm quite sure that at Mount Sinai a lot of research is going on, also with the genetic profiles. And I mean, this brings me to the our kind of future research agenda. So what we would like to do at the end is basically to combine the genetic profile with the electronic health data from the patients with the wearable data, right? So to really have the full picture of the patient, right? So this is one of the big goals we have in this HPI Mount Sinai cooperation.
Thanks. So this line of questioning here brought up the issue of how all this works. It intersects with genomics, because you've got all this going at the same time we're building a greater and greater genomics database. You have a child that's born, undiagnosable condition. You can now run their whole genome overnight. And I think it's down to like what, 7.5 hours now. How do you pull that and pull it with this? Because that goes to those specific type issues that you're getting into, and blend that to create a better picture. Because it's blending that data set, all the data governance and everything that comes into play. How are you and your team sort of tying those two pieces together?
Well, I mean, the thing that we are doing now is basically to first come up with this data set, right? So the genetic data for a very huge population at Mount Sinai is already there. The electronic health data is also there. What is now missing is data from daily life, right? And we're currently in the planning phase to use those wearable devices to gather data from those patients where we already have genetic information, where we already have electronic health records, and we would like to augment this with data from daily life, right? So this is kind of our approach to get the full picture of the patients, and then it will be very interesting to see if we, for example, see those differences in the genetic subclusters for certain data that we got from the wearables. We don't know yet. We have maybe a few ideas what we might expect, but we can't tell yet because we don't have the data yet. But soon we'll have the data, and then having the full picture of many patients, we hope to generate a lot of new knowledge that is simply not existing yet.
Okay, well, thank you, Bert, for an excellent presentation.
Thank you for all the exciting questions, right? So maybe next time we start with the questions, right? Before showing my presentations, because you actually mentioned all the important challenges we have. So thanks a lot for your questions.